Good day, this is Great Surgeon. Today we're gonna talk about a very interesting, important chapter in the MRCS and in your life, whatever your specialty is. It is the abdominal wall from the GIT chapter. The abdominal wall surgery is overlapping with many chapters. Of course, our pillar, the anatomy. If you understand the abdominal wall and pelvis anatomy, you will understand what is all about in the abdominal surgeries, as well as the pediatric surgery and the abdominal surgery techniques. So, have your favorite drink and let's crack this lovely chapter together. Together we can with the grace of God. If you want to study a certain topic in GIT and abdominal wall, and it will come in the exam, it will be the hernia. The hernia is a pillar in every general surgery exam. And by hernia, we mean a protrusion of a viscus through a hole. There is a defect and there is an organ protruding through this defect. This is the hernia by definition. And by definition, we all know the very famous hernia like the inguinal hernia, which is the indirect and direct hernia. Some of you will be familiar with the paraumbilical or the congenital umbilical hernia. But do you know that we have as well the Morgagni and Bogdalic hernias? We have some special hernias as well, like the spiculian and the lumbar, as well as the obturator and the rectus hernia. You have to be familiar with those hernia because they are the diagnosis of exclusion. If they are not in your mind, you will miss it. If you found a baby having an intestinal sound in his chest wall, it's not a transmitted sound, it's a hernia. It's a big issue to have intestine in your chest. In chest, you have only the heart and two lungs. But there is no one want to have his food beside his air. He have to respire air clearly with his lungs without the intestine interrupting this operation. So never forget the other types, special types of hernias. We have two special types from congenital diaphragmatic hernia, the Bogdalic and Morgagni. The Bogdalic will be associated with hypoplasia on the affected side, and it's 85% of the cases. And by the way, it's more common. It's found mostly due to congenital diaphragmatic hernia in the pleuroperitoneal membrane, mostly in the left back, Bogdalic in the back, while the Morgagni in the front. And it's less common than the Bogdalic, of course. By the way, the congenital diaphragmatic hernia are urgent and not emergent. This means you have to resuscitate the patient and give him a mechanical ventilation at first because the lung will be hypoplasia on the affected side. So you can't do your anatomical apposition repair without preparing the patient first. Take care from this track in the exam. You have to prepare your patient first. So it's an urgent, not emergent. Another very famous hernia related to the diaphragm is the paraesophageal hernia. It occurs when the lower part of the esophagus and the stomach or the organs move above into the chest through the hiatus hernia, the hiatus opening within the diaphragm. Take care. Of course, you all know that the paraesophageal hernia can be treated with an operation called Nissen fundoplication. So paraesophageal hernia is a developmental diaphragmatic hernia that can be cured by Nissen fundoplication. What is Rectus hernia? Rectus hernia is one of the special types of hernias where it's a condition where a part of the wall of the small bowel, usually the anti-mesenteric border, which is the border that is against the mesentery. You know that the mesentery is the blood supply of the bowel. So the anti-mesenteric border, the other border not facing the mesentery, is always involved in the rectus hernia and is strangulated within the defect of the hernia. They don't present with typical feature of intestinal obstruction as luminal patency is preserved. The lumen of the intestine will be preserved, while the rectus hernia only a part of the wall of the bowel will be strangulated, so he will be passing stool but he might come late with diarrhea due to strangulation, where vomiting is prominent and usually occur as a result of paralytic ileus. So, rectal hernia is very famous to come to you with open bowel paralytic ileus or peritonitis. By the way, in practice, I have noticed two cases of Rectus hernia. It was mostly with the umbilical hernia. In the para-umbilical hernia, the Rectus hernia is very common. You can see like a mini balloon, like through the abdomen. You click it with your hand, you find the patient in severe agony, in severe pain. This is due to the Rectus hernia, a part of the bowel, not the whole human. So he will be open bowel until he strangulates. If you are familiar with the inguinal hernia, you have to know special types of inguinal hernias, like the content differentiate what is the name of the hernia. So, for example, the lateral hernia is a hernia containing Meckel diverticulum. How about the amient hernia? The amient hernia is due to presence of the appendix within the hernia. And of course, if it's infected or inflamed, you can't put a mesh during the hernioplasty. Take care. Pantalon hernia is a pantalon hernia named that it has direct and indirect hernia in the same patient on the same side. So pantalon hernia is direct and indirect hernia within the same side. But if a patient have two hernias on two sides of the inguinal region, it will be called bilateral inguinal hernia. And of course, we all know that bilateral inguinal hernia is better to be treated by laparoscopy. Great. Please, great surgeon, don't confuse the names of the hernia. I know it's a little bit about memory. We have amient and medial hernia. The amient hernia is not the medial. The medial when you have a W shape loop within the defect, while the amient when you have the appendix within the hernia sac. Take care. Amient and medial. Amient is the appendix. Medial is about, yes, W-shaped loop. Why you should know the medial hernia? We all know that the amient hernia, when we have the appendix, and should be cautious and take care that we don't do hernioplasty when there is an inflamed appendix within our hernia. So why would we know a W-shaped loop within the outer sac of the hernia should matter? Because if it is strangulated or rolling over each other or obstructed, it should be inspected. Don't be deceived with the apparent loop inside your eyes. So you have to watch for yourself for the whole W shape which was in the sac. Don't reduce it to the abdomen and inspect it clearly under vision. Is it obstructed or strangulated or not before reduction or before repair? If you have a recurrent hernia, it will be a recurrent hernia. But if you have done, for example, an appendectomy and an hernia appeared within the appendectomy scar, this is called incisional hernia. It's a hernia due to a previous operation. But if you done a repair to a hernia and it came back, it's called recurrent hernia. During your repair for incisional hernia or recurrent hernia, both you have to be in a new plane, clear plane, away from the previous operation. Otherwise, you will be in a very messy operation site. Yes, you go from the same scar, never go wrong by going through an old scar, but please go through a new plane to reach your defect, because if you reach your defect through the same situation, through the same old fibrotic tissue, it will be white fibrotic tissue and you can't repair it. Take this rule in whatever specialty you are. You never go wrong by going through the same old scar, but when you are inspecting for the subcutaneous tissue fibrosis, please go through a clean, clear plane. If we have to mention the obturator hernia, which is very rare and more common in female, It's between the pectineus and obturator externus muscle and often present with incarceration and mostly diagnosed very late. And as well as the femoral hernia is more common in female as well. It's the hernial sac within the femoral vein compression. Take care. Is the medial aspect of the femoral canal. This is the femoral hernia. You have to take care from it. And by mentioning that the femoral hernia or the obturator hernia are more common in female, but still the inguinal indirect hernia is still the very most common hernia of all types. The most common hernia in absolute is the indirect inguinal hernia. Medicine is incidence, and this is a direct rectal question, by the way. By mentioning indirect inguinal hernia, the indirect inguinal hernia, it's from the internal ring to the external ring, while the direct inguinal hernia, it's directly through a defect or weakness in the anterior abdominal wall muscles, while the indirect inguinal hernia takes the whole journey from the internal ring passing through the inguinal canal to the external ring, and it can go through the scrotum, so it might present as inguinoscrotal hernia. This is the indirect hernia, while the direct hernia, it can form a pupionocele, like a small bulge in the groin area above the scrotum and separated from the testicle, and the scrotum never reaches the scrotum because it's due to a defect or a weakness within the abdominal wall itself. Take care. Again, take care. You never go wrong by going through the old incision scar. But we are talking about a clean plane through the fibrotic tissue. Of course, an incisional or recurrent hernia, you will open the same old scar. But below this scar, the fibrotic tissue, you can't dissect your tissues within this fibrosis. Take a new clean plane. Don't confuse the scar with the plane below the scar. If you are a geeky medicine loving new knowledge, we said that the ambient hernia is inguinal hernia containing appendix. But what if the femoral canal containing the appendix? It's called Garnigot. Garnigot. Garnigot is a femoral canal containing appendix. This is only for the geeky medicine, not for literature or out of the MRCS scope, by the way. Another famous hernia is the Violin hernia. It's along the linea semilunaris at the junction of the lateral abdominal muscle and the rectus sheath. You all know that the continuation of the anterior abdominal wall muscles, the external oblique, internal oblique, and fascia transversalis and transversus abdominis all converge to form the linea alba, which continues and forms the rectus sheath. So, this Violin hernia is along the linea semilunaris, which is the junction between the muscles of the anterior abdominal wall and the rectus sheath, and this is the junction of the lateral abdominal muscle and the rectus sheath, where you can find this Violin hernia, a special type. And the trick here, you have to preserve the insertion of the muscles and attachment while you repair. Take care. In the exam, it might ask you about any of the hernias we talked about directly, or ask you about the incidence. We all know that the indirect inguinal hernia is the most common of them all, even in children. But take care. He might ask you about the anatomy of the inguinal hernia and the inguinal region and the inguinal canal. That's why we said and agreed that they are overlapping. Keep this in mind. So let's review the inguinal canal anatomy together. So the inguinal canal is a short passage that extends inferiorly and medially through the inferior part of the abdominal wall. It's superior and parallel to the inguinal ligament. So when we mention the inguinal canal, keep in mind you are in relation with the inguinal ligament. The canal serves as a pathway by which the structure can pass from the abdominal wall to the external genitalia, especially in males. It's of clinical importance as a potential weakness where the abdominal wall can go herniation, of course. So, from the internal inguinal ring, the internal inguinal ring defect will cause indirect inguinal hernia, while the weakness in the anterior abdominal wall will cause, yes, direct hernia. So, take care. In the exam, it will ask you directly about the inguinal canal boundaries and the inguinal canal content. So let's be familiar with the boundaries of the inguinal canal. The anterior wall, of course, it's the aponeurosis of the external oblique, which is reinforced by the internal oblique muscle laterally, but mainly the external oblique anterior wall, while the posterior wall will be the fascia transversalis. And take care, the clinical appliance of this fascia transversalis is that the internal ring is within the fascia transversalis, and the repair will be within the fascia transversalis internal ring, where you can put your mesh over the fascia transversalis. So the tension-free mesh in the Liechtenstein repair in the hernioplasty in adult will be within the fascia transversalis, while in herniatomy in children you will do only cut of the patent processus vaginalis, which is the reason for the inguinal hernia in the children. It's not about the internal ring. The child will still develop his internal ring and external ring canal. In the children, it's not developed the canal, because the internal ring and external ring in children will be facing each other. And the problem is not the canal, it's about the patent processus vaginalis. There is a sac which is the problem. When you cut the sac, you solve the problem in children. But in adult, it's mostly due to defect within the fascia transversalis internal ring. That's why in adult we do a hernioplasty with a mesh, but in children we do only herniatomy. See, this is all from the boundaries. We talked about the boundaries only, and yet we talk about the solution of the hernia. So that's why the clinically applied anatomy matters. This is a very common question in the exam. You might be tracked where you put your mesh over. Some guy get tracked and put the mesh over the external ring. Of course not. The problem is not the external oblique. The problem is not the external ring. It's all about the internal ring, which is found within the fascia transversalis in the posterior wall. So let's continue our boundaries. We agreed that the anterior wall is the external oblique and the posterior wall is the fascia transversalis. The roof will be the fascia transversalis and the internal oblique forming with the transversus abdominis the roof for this canal, while the floor will be the inguinal ligament. Take care. The floor will be the inguinal ligament. Don't confuse. Don't confuse yourself. The inguinal ligament is an important boundary, but it's the floor. It's not the anterior wall. The anterior wall will be the external oblique. The floor is the inguinal ligament. And by the way, the inguinal ligament is the roll-up portion of the external oblique aponeurosis. So it's formed by the external oblique itself. And second, medially by the lacunar ligament, which is also formed by the external oblique. There are 2 points important when we mention the inguinal ligament. The midpoint of inguinal ligament will be the deep internal ring. When we are talking about a landmark that can confuse with the midpoint of the inguinal ligament, the mid-inguinal point. The mid-inguinal point is related to the femoral artery pulsation. If you want to feel the pulsation of the femoral artery landmark, it will be at the mid-inguinal point. But when you mention a midpoint of inguinal ligament, it will be the site of the deep internal ring clinically applied. Take care. And by the way, it's lateral to the deep internal ring is lateral to the epigastric vessel, and the epigastric vessel is the line laterally that divides the Hasselbalch triangle from the direct and indirect hernia. So when you have the inguinal ring, the internal ring is outside the epigastric vessel. This is indirect hernia. But inside the Hasselbalch triangle, which is bounded by the rectus sheath and the epigastric vessel and below the inguinal ligament, you are talking about the Hasselbalch triangle, again the epigastric vessel and the inguinal ligament, as well as the rectus sheath. We are talking here about the Hasselbalch triangle, where you find the direct hernia. Outside this triangle, it's indirect hernia. This is another trick in the exam. Those voice notes are made to listen. They are not made to visualize. I know you might need to visualize, but during your shift or your work, you might not have time to look at any illustration. So hope they help you to imagine and understand the ideas about the rectal questions that might come in the exam. God be with you. Let's continue together. So again, if you missed it, we are talking about the Hasselbalch triangle, which is bounded by the rectus cheese and the gastric vessel, as well as the inguinal ligament. Inside the Hasselbalch triangle, you will find a direct hernia. Outside the Hasselbalch triangle, you will find indirect hernia. And the indirect hernia is the most common hernia of all types, and it is due to a defect within the deep internal ring in the fascia transversalis, and in adult it will be treated by tension-free mesh Hasselbalch, tension-free mesh Liechtenstein repair, while the indirect hernia in the children will be treated by only herniatomy, not hernioplasty. Herniatomy, when you only cut the patent processus vaginalis. Many have been sending me about why it's called herniatomy. Otomy means opening. It's a faulty name, but most of the surgeons kept saying it. In fact, it must be said to be herniectomy. It's a cutting of the patent processus vaginalis and removing of the excess. But in fact, it's a wrong name, but it's kept in the literature until now. Hope one day we can name it Bishoy herniectomy. So in children, the indirect inguinal hernia will be treated by herniatomy. In adult, it will be treated by hernioplasty, tension-free mesh, Liechtenstein repair. And of course, the mesh will be a proline monofilamentous mesh, because it's inert and will not cause reaction, and it's better. It will be tension free. If you want to treat something, prevent it from the start. To prevent a hernia to occur over an incisional hernia over appendectomy scar by saving the ilioinguinal nerve is better than causing incisional hernia over appendectomy scar. And in females, it's better to be done via laparoscopy, because females are complicated. They have various anatomy in the right inguinal region, where the right iliac fossa, you will find they have ovaries, fallopian tube. You will have, yes, they will have the appendix. Many things can be found in the right iliac fossa within the females. So you have to visualize it via the laparoscopy, which is not accessed even with a gridiron incision. And of course, in a female, you will not going to do a gridiron, and you will go for lens incision, because it's better cosmetically. And for visualization and better cosmesis, you will go for laparoscopy in a female as a rule. So whenever you find in the exam laparoscopy for appendectomy in a female, go for it without thinking. It is a general rule, even in real practice. You will save yourself a lot of trouble. By the way, any organ within our viscera can go herniation through any defect within our abdomen, except for the pancreas, because it's a retroperitoneal organ. Take care. The pancreas never herniates. So even the brain can go herniation, but the pancreas never go herniation. And by the way, even the artery and the vessels can go herniation. It's called aneurysm. Aneurysm is a part of herniation. Yes, but it's of the artery. That's why any swelling within our abdomen, or any swelling in our body, you have to suspect it might be either a vessel aneurysm. Take care. Otherwise, you want this man to die in hypovolemic shock. Dear great surgeons, there is a very confusing question for many in MRCS. Question bank. It's all about a young female patient having a right iliac fossa pain. She is nauseating, vomited twice, on examination marked tender and rebound tenderness. Vaginal examination is unmarkable. Urine dipstick is negative for beta HCG. He excluded that this might be anything regarding pregnancy, so it's not ectopic pregnancy pain. And the blood test showed that the white blood count is 13.5. It's high, and the CRP is high, about 70. What should be the next action? In the options, he is giving you open appendectomy, laparotomy, abdominal ultrasound, laparoscopic appendectomy, and all of the candidates are confused between the ultrasound and laparoscopic appendectomy. Dear great surgeons, this patient required laparoscopy. The abdominal ultrasound won't change the decision to laparoscope this patient. So do a laparoscopic appendectomy. It's appendectomy until proven otherwise. Dearest great surgeon, the negative vaginal examination is therefore excluding anything within the cervix excitation and within the ectopic pregnancy probabilities. So it's a pelvic inflammatory disease is unlikely. Given the raised inflammatory markers like the CRP, the correct course of action will proceed with the surgery. It's a surgical abdomen, and the abdominal ultrasound, according to the UK regulation here, won't change the decision. I know, the CT would allow for an accurate pre-operative diagnosis, but it carries a significant radiation dose and it doesn't alter the management and doesn't change the management. So take care. Laparoscopic appendectomy is the route for female, especially when she is a surgical abdomen and you have excluded other causes like ectopic pregnancy. And by the way, the laparoscopy will be a complete visualization of the inside of the surgical abdomen. If it's not a surgical abdomen, you can get another investigation to make sure what is this. And by the way, when we are talking about right iliac fossa pain, especially in female, you will have to consider the organs within the right iliac fossa, from the ovaries, fallopian tube, as well as the uterus itself portion. It can be transmitted pain through this pain, as well as the ureteric pain and renal pain, not only the appendix. And not only the appendix and those organs. You have to consider as well having appendicitis, chronic disease, Crohn's disease, mesenteric adenoids, diverticulitis, mecal diverticulitis, perforated peptic ulcer even can cause a right iliac fossa pain. Yes, it's mostly perforated peptic ulcer will be epigastric pain, but it can be transmitted there due to an generalized peritonitis. It will be a port rigidity. How can you make sure this perforated viscous is a perforated duodenum or perforated appendix? The incarcerated right inguinal or femoral hernia can cause as well a missed diagnosis. Even the right inguinal hernia may be an ambient hernia. So take care, the ambient hernia is due to the presence of appendix within the hernia, which might be inflamed, or it might be Rectal hernia, where you have a mecal diverticulum inside your hernia. Take care. All of those are differential within the right iliac fossa in females. Even gynecological causes and urological causes and metal schmers, where a mid-cyclic pain can be caused in the young females. You have to consider all of those differentials within your differential diagnosis. But what is common is common. Appendicitis is the most common pain within the right iliac fossa. Keep in mind. Take care. From the very important differentials for appendicitis and right iliac fossa pain in young patients are the mesenteric adenoids. It mainly affects the children and caused due to adenovirus or Epstein-Barr virus or beta-hemolytic streptococcus or staphylococcus, or even the Escherichia coli can cause this. And by the way, the patient will have a higher temperature than those of appendicitis. And if a laparotomy was done for a mesenteric adenoitis patient, you will find the lymph nodes are enlarging. So with a very efficient ultrasound, you will find there is a mesenteric lymph node. So don't open this patient. This is a mesenteric adenoitis and will be self-limited. While a Crohn's disease, if you opened a Crohn's disease for appendicitis, you are this lucky surgeon who is going to perform a right hemicolectomy most probably. Take care. You have to take the history from the patient, because you will have a very long history of a strange bowel habits and there is a signs of malnutrition. So a change in the bowel habits and especially diarrhea, and long history of this strange bowel habits with malnutrition. This is not a female patient who is not willing to eat. she might be a Crohn's disease. Don't be this lucky surgeon. Please open for appendectomy. Don't open for a Crohn's disease. It's a nightmare for the surgeon. But if you open the patient suspecting any of the differential within your differential and you didn't find anything, the appendix is normal. You find that there is no ureteric stone within the ultrasound, there is no torsion ovary, and the fallopian tubes are intact. What could this be? Yes, this might be a Meckel's diverticulum. The Meckel diverticulum is a congenital abnormality that is present in about 2% of the population, and you will be a lucky surgeon to find a Meckel diverticulum. Take care. It's typically 2 feet proximal to the ileocecal valve. So whenever you find the appendix is normal and everything is normal, search for the Meckels. Never forget the Meckels. Never forget it in your life. Never forget it in your exam. It will be your only logic differential within this surgical abdomen. It is the surgical abdomen for Meckel diverticulum must be in your mind when you open and find the appendix normal. And by the way, regarding another recall question for Meckel diverticulum, that it might be lined with ectopic gastric mucosal tissue, like the pancreas for example, and it might cause bleeding as well. Keep it in mind. Dear great surgeon, regarding the right iliac fossa pain, don't confuse the Mittelschmerz pain with the Fitzhugh-Curtis syndrome. Mittelschmerz is the mid-cyclic pain in a normal female. It happens to all ladies. But regarding the Fitzhugh-Curtis syndrome, it doesn't happen except if it's a disseminated infection with chlamydia, seen in female, which consists of evidence of pelvic inflammatory disease together with a perihepatic inflammation and subsequent adhesion formation. During the investigation, an abdominal ultrasound scan may show a free fluid collection, and high vaginal swab may show evidence of sexually transmitted infection. Usually, it's medically managed with doxycycline and azithromycin. This is the Fitzhugh-Curtis syndrome, while the Mittelschmerz, it's only in females in mid-cyclic pain. It's normal event, happens to all the females. And usually, it will be subsided within 24 to 48 hours, and the manage is conservatively. You can only give her a painkiller. Don't open a female for Mittelschmerz. And neither do it for a Fitzhugh-Curtis syndrome. We are knowing some differential so as not to open this abdomen. It might mimic a surgical abdomen, but they are not a true surgical abdomen. That's why we are studying something like pancreatitis, so as you don't open for pancreatitis. The only time you can open for a pancreatic infection is a necrotizing pancreatitis. And you can't confirm a necrotizing pancreatitis except you have an aspirate, and cytology tells you this is a necrotizing pancreatitis, gangrenous, and require drainage. And it's fatal operation, by the way, with a high mortality. That's why a Fitzhugh-Curtis syndrome, its infection should be treated, while the Mittelschmerz is a mid-cyclic pain which managed by painkillers only and happen to every female. If you are interested in science and in medicine, you will like that there is a funny surgeon who termed the sign of the adhesion between the liver and the peritoneal cavity of the Fitzhugh-Curtis syndrome the violin string sign. The violin string sign is the adhesion between the liver and the abdominal wall with the Fitzhugh-Curtis syndrome. That's why a complication of the pelvic inflammatory disease can cause perihepatitis and inflammation between the hepatic capsule and the diaphragm called violin string sign. This can present as pleuritic chest pain and may or not show a symptom of PID. Of course, it will cause PID. It's a cause and a result. A violin string sign. He must have been playing violin for his beloved female while she having a Fitzhugh-Curtis syndrome, and he opened her abdomen and found the violin with her liver. Aren't surgeons are romantic? You should marry a surgeon because they are romantic. They are funny. They are naming the signs like coffee bean, violin string. Even in the pain, she is in pain and he is naming her a violin string sign. Anyway, let's go study. So, Vitz-Hughes syndrome should be treated with doxycycline.